Thank you everyone for joining us for this session. Today we're going to have our continuous medical education session with Dr. Fitsum T Hailemariam on SGLT2 inhibitors and CKD in all. So thank you for being part of this session. To start with, let me tell you a little bit about YetenaWeg, and I'll continue by introducing our guest, and I'll leave the floor to our guest. So, can you see my PowerPoint? Good afternoon, everyone. Thank you for joining us. I see nearly 70 participants here. Thank you for joining our session. Today, we're going to have a session on SGLT2 inhibitors. So let me tell you a little bit about YetenaWeg. As you know, most of you have already heard about YetenaWeg and about our CMEs. And so, as you know, it is a volunteer network of health professionals. And CME is one of the components where YetenaWeg works. It works on community outreach, mentorship, research in QI, health promotion, and health advocacy. So we would say you shall not miss on our regular CME, which we collaborate with EMA, Ethiopian Society of Cardiology Professionals, as well as Ethiopian Dermatology and Virology Society. So we've prepared this CME previously. You can find it on our YouTube link, on YetenaWeg YouTube link, and you can find updates on our CMEs. And let me move this. Yes. We've got, for this year, we have nearly 40 webinars planned. So make sure to join us with our social media platforms to know about our next CME. As you have heard about, YetenaWeg in Roha has a plan for research fellowship for this year, together with Rambis Hospital. And so our mission is to advocate health, networking, and filling the knowledge gap, as well as encouraging local funders. So what we planned is to work with 3 departments in Addis Ababa University: Oncology, Radiology, Internal Medicine department, in having a research fellowship, and it was launched on March 14. Added with that, Roha has helped us in for medical students. It has planned to give research grants for 2 winners in St. Paul Hospital Medical College, and it will be launched soon. We would like to thank Roha for also giving us opportunity to give writing competition in collaboration with EMSA, which it gave prizes for top 3 winners. And so when we come to our CME, we like to tell you that we'll be giving 2 CU units along with EMA, and you need to attend the whole session virtually, and you need to fill in the form, which I'll be sharing at the end of the session. And you are supposed to get 50% and above to get your certificates. And we would like you to be patient with us to give the certificates, as EMA is going to give the certificates after 1 to 2 weeks after the session. So without further ado, let me introduce to you Dr. Fitsum. Dr. Fitsum Hailemariam is a highly accomplished medical professional with a wealth of experience in the field of nephrology and transplant nephrology. He received his medical education from Addis Ababa University College of Health Science before going on to complete his internal medicine training in St. John Episcopal Hospital. He furthered his education in nephrology and transplant nephrology in Thomas Jefferson University Hospital, where he is now serving as assistant professor of medicine and nephrology. Throughout his career, Dr. Fitsum has received numerous awards for his outstanding leadership and teaching abilities. He was recognized with an outstanding intern award from Addis Ababa University School of Health Science and a certificate of recognition from Dodoma Hospital for excellence in leadership, and was placed in honor roll at Thomas Jefferson University Hospital for exceptional teaching. In addition to his academic and professional accomplishment, as you all know, he is our co-founder of YetenaWeg, and which, as you know, is a volunteer network for healthcare professionals. which has been actively engaging for over the past 3 years. And we are really thankful to have Dr. Fitsum with us to talk about SGLT2 inhibitors and impact on kidney disease. So I will leave the floor to Dr. Fitsum, and we hope through this session, everyone joining us live as well as seeing the one recorded would be able to prescribe this medication. As we have noticed, this medication is not being prescribed, even though it's being provided for free in our country. So Dr. Fitsum, I will leave the floor to you. Thank you.
All right. Thank you. Thank you, Sagata, for the warm introduction. I really do appreciate the your introduction. Thank you, YetenaWeg team and the Ethiopian Medical Association and the attendees here today joining us to discuss about SGLT2 inhibitors. This is a topic I'm really excited about because, as you may have been following on recent publications, how much benefit they provide in terms of slowing the progression of kidney disease. Not only that, protection of the heart, decreasing mortality and hospitalization. So I'm sure they are already a standard of care in many different branches of medicine already. So it's something that as medical students or different levels of healthcare professional that you need to familiarize yourself how to prescribe SGLT2 inhibitors, how they work, mechanism of action, and more. So I'll go through that through the slides. My slide could be a bit much. Some of them I'll skip faster, but I will share you the slides at the end. You'll be able to get the slides on the Telegram channel. So don't worry about that. I'll start sharing my screen. All right.
We can see it now.
Perfect. Can you see it now?
Yes.
So again, like I said, we're talking about SGLT2 inhibitors and chronic kidney disease. This is in part presented in collaboration with YetenaWeg and Emma. I'll ask you later on why I put the picture of an apple in SGLT2 inhibitors. They have some meaning. Okay. Here. So I don't have any conflict of interest to present this topic. I don't have any relations with the pharmaceutical companies or with any of the medication, but I'm very passionate about prescribing this medication. So that's the only new thing that I need to disclose here. Through this presentation, we'll go through introduction, understanding what SGLT2 inhibitors are and why chronic kidney disease is important and the prevalence and incidence. And then we look into the early cardiovascular trials that show the benefit of SGLT2 inhibitors in cardiovascular outcomes. And then later on, we learned about their renal benefits, and we started to have those landmark trials in nephrology, including Credence, the DAPA and IMPA CKD trials that showed significant renal benefits. So we'll go through that, and then we'll look into some benefits beyond the heart and kidney that is widely discussed. And finally, I'll give you some tips about the real-life prescribing of SGLT2 inhibitors and what are some things that you need to understand or look into. So that everybody could be on the same page, sometimes I could be saying SGLT2 inhibitors. They are basically, it means a sodium, that's for the S, glucose transport proteins. So SGLT2s are sodium glucose transport proteins. They are co-transporter proteins. They move glucose and sodium at the same time. They're co-transporters. There are different types of SGLT2 proteins. SGLT2I is found in the small intestine, and it absorbs glucose to our body. We call it SGLT2. The SGLT2 is found in the proximal tubules of the kidney. They are responsible for 90% of the absorption of glucose in the kidney. So sometimes I may say sodium glucose transporter, sometimes I say SGLT2, but it just means a sodium glucose transporter. The other point I want to define is chronic kidney disease. When we say SGLT2 inhibitors and chronic kidney disease, CKD means a presence of decrease in kidney function as measured by GFR of less than 60 ml per minute that is present for more than 3 months, or a presence of a marker of kidney damage. When we say marker of kidney damage, it could be albuminuria or proteinuria. that shows some podocyte damage, right? Or presence of urine sediment abnormality, be it hematuria or other casts, or kidney transplant, or any other structural abnormality that you may see on the kidney imaging. If you have either a decreased kidney function or some evidence of structural damage to the kidney, and that is present for more than 3 months, that is defined as chronic kidney disease. And you can further classify chronic kidney disease. Here on the right side, you have the heat map. This is based on the KDIGO 2021 standard classification of CKD. So as the GFR decreases further, it goes from G1, G2. So the ones, for example, G5 is when a GFR less than 15. And then albuminuria is defined as A1, A2, and A3. A3 is when you have albuminuria more than 300 milligrams. So the lower the GFR and the higher the albuminuria, the heat map shows higher risk of progression to end-stage kidney disease. So whenever you have a patient with chronic kidney disease, try to have both measure of their GFR and their albuminuria as well, so that you also could understand the risk of progression. So why CKD is important? Chronic kidney disease has been an increasing global burden in terms of the disease prevalence and outcomes over the past 20 plus 30 years. This is a study published in 2016 in Kidney International, looked into the incidence and prevalence of chronic kidney disease over the last 20 years. The incidence of chronic kidney disease has increased by almost 90%. The prevalence has increased by 276 million. It means in the last 20 years, we have added almost 300 million people with chronic kidney disease to the already existing number of people living with CKD. And the days from CKD has increased by almost 100%, like more days as we have seen over the last 20 years. There are a lot of factors that contribute to that. The increasing life of urbanization, increasing obesity, increasing prevalence of diabetes could be a factor. But the fact is we have more CKD than we ever had before. This is a data from CDC from 2021 from the US. Almost 1 in 7 people, or 15% of the population in the United States, have chronic kidney disease. That's 37 million people. So that's a lot of people living with CKD, and it's not something that we can ignore. I tried to look into some data into chronic kidney disease in Ethiopia. This is a meta-analysis and systemic review published in 2021 in Public Health Review paper. So on all the slides, I have put the link to the paper. So when you look into the slides, you can further look into the study. So the analysis found that the burden of chronic kidney disease in Ethiopia is somewhere between 18 to 36%, which is a very wide, statistics, like say from 18 to 36%. But as you see, most of the studies were done like in a single hospital or a single region. We don't have a countrywide data to look into the prevalence and incidence. So you have to look into these numbers with a grain of salt and see, is it really true or not? But at least we have a rough estimate of what the CKD looks like in Ethiopia. So it showed there is increased, like everywhere else, there is increased incidence of chronic kidney disease in patients with hypertension and diabetes. And the incidence of chronic kidney disease is much higher the longer you have diabetes, which is, of course, something that you think is right. Looking into the age distribution of chronic kidney disease, again, this data is from the US, but consistently across the board, we know elderly patients who are older have higher risk of chronic kidney disease. As you can see here, patients who are 65 years and older and above have higher incidence of CKD, almost 3 times higher than those who are younger, between 18 to 44 compared to 65 and plus. There is very high increased incidence of CKD in those population. In the US, there is higher risk of chronic kidney disease in African Americans and non-Hispanic Blacks. Some of it has to do with genetics. For example, APOL1 gene, which causes rapid progression and fibrosis of kidney in Black patients. That may be true for our case too, because some of those genes are derived from our African heritage here. So we might have increased incidence of CKD as well. Again, looking back into the data, this is a 20 years progression of chronic kidney disease over the last 20 years in the US. The increased incidence of prevalence of chronic kidney disease is evident. As you see, the graph is going up and up every year, but majority of the increase in CKD is partly because of the stage 3 chronic kidney disease. the early stage and the late stage of chronic kidney disease, the numbers have been pretty much stable over the years. The reason I wanted to point out is chronic kidney disease is a global health problem, an Ethiopian health problem, a problem in the US, it's a problem everywhere. So we need to screen it and look for CKD based on either GFR or albuminuria in all our patients, particularly in the elderly group who are at high risk. Looking into causes of end-stage kidney disease, this is a data from US data renal system. They studied the patients on dialysis and looked back into their chart and what was the documented cause of kidney disease. So if you see here, this green part, 40% of end-stage kidney disease is because of diabetes. The rest, 26% is from hypertension. So almost 70% of chronic kidney disease attributed to diabetes and hypertension. So you can understand how diabetes plays a very significant role in end-stage kidney disease. Now, understanding that there's a lot of chronic kidney disease and diabetes plays a part, I looked into this paper, which was published in, I think, 2014, yes, in the New England Journal. So they looked into the diabetes-related microvascular and macrovascular complications, diabetes-related acute myocardial infarction, diabetes-related CVA, amputations have decreased over the years. This is a data over from 1990 to 2010. So while other specialties like cardiology, neurology, and peripheral vascular disease and amputation have decreased, you see the dip in the graph. But diabetes-related end-stage kidney disease haven't showed marked improvement. It's almost the line is straight over 20 plus 30 years. So either as a nephrologist or primary care physician, we haven't done a good job in terms of protecting progression of diabetes-related kidney disease. Partly that could be because we didn't have any new medications over the last 20, 30 years that can treat diabetes-related kidney disease. If you look into this picture, this is all the studies that were done in nephrology over the last 23 years. It starts from 1998, it goes all the way to 2019. So you have all the major landmark trials listed here. So the smiley faces show a positive outcome that showed benefit in preventing progression of kidney disease. And the sad faces are showing, no negative trials, or the trials have been negative, didn't show benefit. So the only time we were smiling in nephrology was almost like 20 plus years ago in the late 90s and early 2000s, when we understood first this UKPDS study, which is still going on, looked into glycemic control, or in diabetes patients, having a good control of diabetes slows the progression of kidney disease, which is obvious, but it was not understood that time. And after that, in the early 2000s, we looked into ACE inhibitors and ARBs, the renal study, and IRMA with irbesartan showed there is significant reduction of albuminuria, and that ACE inhibitors and ARBs slow the progression of kidney disease. This is 20 plus years ago. And since then, what we did is just a combination of ACE and ARBs and other medication, which, as you can see here, did not show any benefit. And the only time we started to show something positive was with the introduction of SGLT2 inhibitors, which is a 20 years ago. And that's why I'm very interested to talk about this topic. CKD is a major problem. Diabetes is a major factor for chronic kidney disease, and we didn't have a lot of medication except ACE and ARBs for more than 20 years. And now we have SGLT2 inhibitors. Again, this is a list of all the negative trials that happened on the last so many years. We've tried, but there was nothing positive outcome. But you can go look into the details of those trials if you're interested. So now I'm starting my talk with SGLT2 inhibitors. Like I mentioned earlier, they are sodium glucose cotransporter proteins. And for many years, we didn't really understand how our body absorbs glucose and how our kidneys also reabsorb glucose from the tubules. So our early understanding came in the 1980s when NIH scientists and clinicians looked into those transported proteins, and they found out that SGLT2I, the one is found in the small intestine, absorbs glucose, and the SGLT2 receptors are found in the proximal tubule, and they are responsible for 90% of the glucose reabsorption. So understanding that we have those receptors who are responsible for reabsorption of glucose and the kidneys. The next thing as a scientist or the clinician would do is, if we block those receptors, would it help treat diabetes? Would it help? Can we use them as diabetes medication? Of course, if you stop reabsorption of glucose, that may be a way to treat diabetes with the help of the kidneys. That's exactly what the clinician and scientists in NIH did. So they looked for any, possible substances that can inhibit those receptors. And they found that an extract from a bark of an apple tree called the flozin that actually can inhibit the SGLT2 receptors in the kidney. And this is a naturally found extract. That's why I was earlier saying maybe an apple a day could keep the doctor away. And then the NIH again did additional research on SGLT2 inhibitors. And from earlier studies from genetics, we know that there are some people who have a genetic defect that causes inactivation of their SGLT2 proteins in their kidney. And those patients, even if they have this defect, and we know that they have glycosuria because their receptor is not working and they're going to lose all the glucose in the urine. It's called familial renal glycosuria. But because of reasons that entirely not understood by that time, those patients didn't really have hypoglycemia or major health side effects. And that's also another proof that maybe SGLT2 inhibitors may be a safe drug to use, but we'll look into that. So scientists looked into substances that could, inhibit those receptors. And then once we have that information, of course, big pharma comes into the play and they try to make new medication. So the first one that came into the market was canagliflozin, marketed as Invokana here. It was first released in 2013. Then we have dapagliflozin, and then we have empagliflozin, almost around the same time. They were initially prescribed, or they were initially out in the market probably as a third line or fourth line diabetes medication. You have metformin, insulin, and the other medications who are first line. Nobody would think treating diabetes by blocking receptors in the kidney would be the best way to treat diabetes, of course. And that's why they were, if you look into the guidelines back in the days, when I say back in the days, like 10 years ago, they were not the first line medications. But the good thing was there was a 2008 guideline or recommendation from FDA. This is a list of medications that are currently approved by FDA for use. It's basically canagliflozin, DAPA, and empagliflozin. But there are some combination medications between canagliflozin and metformin, and dapagliflozin and metformin. So I don't know if they are available in the market, the combination medications, but it can decrease definitely the pill burden for your patients. So this was a guideline I was talking about. The FDA guideline in 2008 said any diabetes medication that's released into the market has to show some cardiovascular benefit. And previously we have been burned with some medication released as diabetes medication and later found to have increased cardiovascular mortality, increased cardiovascular morbidity. So this guideline said, of course, if you're treating diabetes, you need to show the end result, and you need to show that it ultimately prevents the problem, the cardiovascular outcome. So with that, the pharmaceutical companies started the early cardiovascular trials. So this is not renal trials yet. So this is cardiovascular trials. So IMPREG started in the result came here around 2015. So empagliflozin cardiovascular outcome trials came around 2015. The canagliflozin cardiovascular trials came late in 2017, and DECLARE came later after the Credence ended. But again, like I said, those early trials in SGLT2 inhibitors were cardiovascular trials. They looked into MACE, which is major adverse cardiovascular events, and across the board, whether it's EMPA or canagliflozin, they showed a significant risk reduction in cardiovascular outcomes. You see here a 14% risk reduction, again, consistent again in the CANVAS trial. And in the dapagliflozin trials also, it showed decreased incidence of cardiovascular outcomes. They didn't look into kidney outcomes yet, but because they have a large study group and the study population was in the 10,000 or even 17,000 in the declared TME, they looked into secondary outcomes for kidney. And there were some signals even then that this medication may have significant benefit in terms of preventing progression of kidney disease. You can see here, kidney outcomes were looked as secondary outcomes. They looked into progression of to end-stage kidney disease and doubling of serum creatinine. And in CKD, the risk was almost reduced by half, and in Canvas was almost 40% risk reduction. But you cannot take those to heart because these are not primary outcomes of the study. Again, I'm just highlighting my point. Both the DECLARE, Canvas, and IMPA trials were cardiovascular trials. So most of the study population have a GFR above 60 and very low albuminuria in the green range. These are not your typical kidney patient that you see in nephrology or in your clinic as well. Most of them have high degree of albuminuria and lower GFR, and they're in the red zone. So by studying patients in the low risk zone, you cannot say this medication would work. So you need to have patients in the high risk group or in the red group to look really into renal outcomes. That's why Credence comes. Credence is the study of canagliflozin in renal outcomes. So they studied important renal outcomes in patients with type 2 diabetes and who have established chronic kidney disease. I discussed earlier what I mean by chronic kidney disease, either a decrease in GFR less than 60 or significant albuminuria in urinalysis. So Credence looked into effect of canagliflozin in patients with type 2 diabetes with GFR. Oh, sorry, what did I do? So they looked into patients with GFR between 30 to 90. This is the first time we lowered the GFR to 30. In the previous studies, we didn't have patients with GFR as low as 30, and they included patients who have significant albuminuria between 300 milligram up to even 5,000 milligram. And the one thing I like about the Credence trial is this medication, the canagliflozin, was given on top of the standard of care. All the study participants were receiving either ACE inhibitors or ARB, and then the canagliflozin was added on top of that. So the primary outcome for this study was to look into progression into end-stage kidney disease, or whether there is doubling of serum creatinine and renal or cardiovascular related deaths. And as secondary outcomes, they also looked into deaths from cardiovascular or hospitalization. They looked into all-cause mortality and other things. This is just key inclusion criteria. Again, those above 30 years were included. And I want to highlight those medications, or the study was done on top of the background use of ACE inhibitors and ARB. This has important implication because some clinicians tend to be afraid to add SGLT2 inhibitors when the patient's already on ACE inhibitors, since they both decrease the GFR a little bit. But you will see it later, the benefit was seen in the background of use of ACE inhibitors and ARB. So comparing the previous trials to Credence, the previous cardiovascular trials included patients with low renal risk profile, but the Credence trial had patients with lower GFR, as you can see, in the 45 to 59 range, and the albuminuria is higher. So they looked primary renal outcomes. The benefit was obtained over the background maximal tolerated RAS therapy. So what did we find? So this is table 1. Always when you look into a research paper or a journal, this table or table 1 is the most important that you have to look. The average age of the study participants was around 62 to 63 years, which is a typical age of most of the patients with chronic kidney disease that you see. The presence of cardiovascular disease was almost 50% in this study group. And the average hemoglobin A1C in this patient was around 8.3, which shows it's not really optimally controlled patients, like typical of most of the patients we see. And the mean GFR was less than 60, whether in the canagliflozin group or in the placebo group. And the most important thing again here is the proteinuria or the albuminuria level was very high, almost 1,000 milligram compared to the previous study, which was very green, right? Again, looking further into the Credence study, they have almost 30% of patients who have a GFR less than 45. This is a CKD stage 3B. So they do have high-risk patients in their study population. And those who have major proteinuria or albuminuria consist more than 75% of the study population. So I think we finally have a study that have our patients, our nephrology patients in their study population. So what did we find? So this is a composite primary outcome, or the primary outcome. This is comparing patients who are taking canagliflozin to just the standard of care without canagliflozin. When we see placebo, you have to understand it's not just they're not taking anything. They are on a standard of care, including ACE inhibitors and ARBs, but the study population had canagliflozin on top of that. So look at the risk reduction in terms of the primary outcome. And this, the graph is nicely separating, starting from the 12 months from the first year, and it goes up, and the widening keeps going. If you continue the study period, it might have even gotten better. So there's 30% risk reduction in terms of the primary outcome of progression to end-stage kidney disease or doubling of serum creatinine. Again, just looking into just renal outcome without cardiovascular death, the risk reduction is even higher. The hazard ratio is 0.66, which means there is, compared to patients who are taking canagliflozin, just a standard of care, there is 34% risk reduction. And again, unlike other medication, the benefit from canagliflozin or SGLT2 inhibitors starts early. By the first year, you're starting to see the graph is separating already. And then progression to end-stage kidney disease, right? So whenever you see a patient with advanced kidney disease or any type of kidney disease, the patient will ask you, like, I'm afraid, doctor, I'm at risk. Like, what can you do to prevent me from going to dialysis or having a kidney failure? So we only had few medications, and learning that canagliflozin or SGLT2 inhibitors decrease the incidence of progression to end-stage kidney disease by almost 32% is very remarkable. So you see here, hazard ratio is 0.68, and the p-value is very, very low, 0.002. So again, looking into other parameters, this is changes in GFR. Always understand that whenever you start this medication, initially you will have a dip of a GFR. Let's say you start a patient with canagliflozin or dapagliflozin, they have a GFR of, let's say, 62 or 55, and then you start them with this medication and check their labs a week later. The creatinine may go higher a little bit, or the GFR may decline a bit, but it doesn't mean it's a side effect or they have an acute kidney injury. That's how the medications work. The same way ACE inhibitors and ARBs work. Canagliflozin or SGLT2 inhibitors will have an initial dip in GFR, but look it over time. By the end of the study period, those taking canagliflozin have higher GFR, and those just taking the standard of care have lower GFR. So the slope of decline in GFR is much lower with SGLT2 inhibitors, so you can slow down the progression of decline in GFR in those patients. And this is the data regarding albuminuria. So the decline, their albuminuria or proteinuria spillage or in the urine has decreased significantly again here in those patients taking canagliflozin. Another important thing, like, of course, our ultimate goal as primary care or outpatient physicians is at least to prevent from our patients going to hospital or prevent hospitalization and prevent death. So when you look into the cardiovascular disease and hospitalization risk, again, those taking canagliflozin or SGLT2 inhibitors have a 30% risk reduction of dying or being in the hospital. So again, looking on all this benefit, reduction of progression of kidney disease, cardiovascular benefit, reduction in terms of morbidity and mortality and hospitalization, you wonder, how do those medications work? And then your first thought would be like, these are diabetes medication. Probably they're, causing a good glycemic control. But funny enough, the A1C change between those taking canagliflozin and the standard of care is not really much different. It's only 0.25. Metformin has a better change in A1C. The other diabetes medication have a better change in A1C. So probably there's another mechanism, but the change in A1C. So if you're trying to treat diabetes, probably they're not the best medication in terms of reducing glycosuria or in terms of reducing hyperglycemia, because the change in A1C is not really high. But that's not the whole picture in managing diabetes, right? It's not just the numbers or the glucose. So we'll look into their mechanisms later, but their impact on A1C is just very modest, 0.25. And then they also have a little bit of lowering of blood pressure. Those taking SGLT2 inhibitors have a decrease in systolic blood pressure, mean of 3.3, probably somewhere between 3 to 5. If I tell a patient to be on a low salt diet, probably would have a better effect. But again, they have blood pressure lowering effect. You want to be careful when prescribing SGLT2 inhibitors in patients who have hypotension or having some volume loss. You may probably want to wait a couple of weeks before you start this medication. So because they have some blood pressure lowering effect. Again, another benefit is they have some benefit in weight loss. So there could be a good medication for your typical diabetes patients with obesity and diabetes. And they, on average, the weight loss is somewhere between 1 to 2 kilograms. It might be higher on some people, might be lower on some people, but the mean difference was just an average of 1 kilograms. It's a good thing because some medication can cause weight gain in diabetes. So how do those medications work? We saw, what sort of magic do they have? We looked, the A1C difference is not that much. The blood pressure effect is not that much. Those are the major causes of diabetes related kidney disease or any end-stage kidney disease are diabetes and hypertension. And the effect of SGLT2 inhibitors on both A1C and hypertension is not that much. How are we seeing this much difference in albuminuria or this much difference in the primary outcome? Is it changing A1C, blood pressure, weight? I don't think this is a mechanism. Sorry. So because of the way they work, there's two main proponents of how they work. One is the tubuloglomerular feedback pathway and the non-TGF pathway. So I'm sure some of you may remember, I don't even remember, like in the earliest renal physiology, you understand the tubuloglomerular feedback, right? So I'll look into this here. This is a very nice review from Nature Nephrology. It was published in 2021. If you want to look in detail how SGLT2 inhibitor medication work, it has a very nice review. So here on the top left corner is a picture of a normal kidney. You see the glomeruli here. You see the afferent arteriole. This is the afferent arteriole. And as you expect, the glomerular capillary pressure would be normal unless the patient is in a disease state. And this is where you have the sodium glucose transporters in the proximal tubules. As it says here, they are responsible for 90% of glucose reabsorption. So what happens in the patient with diabetes is, because you have diabetes, you have hyperglycemia, and there is higher glucose being delivered to your glomeruli. So what happens when you have higher glucose delivered to the proximal tubules is you make your SGLT2 receptors very busy. You have a lot of glucose in the tubules. And when you reabsorb glucose, because these are co-transporters, they reabsorb sodium too. So you have hyperglycemia, more glucose being delivered to the glomeruli, more glucose being delivered to the proximal tubule, and that causes more reabsorption of glucose and sodium. Because of that, the amount of sodium that will be delivered to the distal tubules will be very less. And this is read by your macula densa, or and the juxtaglomerular apparatus. Oh, my body is having less sodium, and I'm sensing low sodium being delivered to me, and the macula densa sends a signal back. There is low sodium, it means low volume, so I need more perfusion. So you can see here, compared to the picture here, the afferent arteriole starts to vasodilate to have more glomerular perfusion. So this causes increased pressure in the glomerular capillaries, and this is a mechanism by which diabetes causes progression of kidney disease. You will have increased filtration, hyperfiltration injury in the glomeruli, and this will lead to eventual glomerular sclerosis or scarring of your glomeruli, which causes progressive diabetes-related kidney disease. So when you have those receptors blocked by SGLT2 inhibitors here, what happens? You have more glucose being delivered here, but you have medications now, whether canagliflozin, dapagliflozin, empagliflozin, blocking those receptors. The more glucose that you have in the tubules is not being reabsorbed and is being delivered to the distal tubules. At the same time, your sodium is not being reabsorbed. So you will have more distal delivery of sodium. What this causes is the macular dense cells understand there's more distal delivery of sodium, and they tell your kidneys back, okay, there is more pressure, there's more sodium, there's more volume, turn it back. So the dilated afferent arterioles will reverse, so there will be reversal of vasodilation, and the efferent arterioles also, there will be reversal. So you decrease the glomerular capillary pressure. So single nephron hypertension, which is a cause of diabetes, glomerular sclerosis, or diabetes-related kidney disease, will be reversed because of that. You are normalizing the capillary pressure in the glomeruli. So this is the tubuloglomerular feedback pathway. The main pathway we understand could be why these medications are causing increased benefit. Again, but there are additional pathways those medications work. Again, this is from the same paper I mentioned earlier. The link is down here at the bottom. So main mechanism is by altering the tubuloglomerular feedback pathway, but we know they also have some benefit in the reducing hyperglycemia. They have some effect on improving hypertension, but they also have additional benefit that are proven. Those are proven benefits of SGLT2 inhibitors. So they stop podocyte loss, they improve obesity and lipotoxicity in the kidneys, they decrease inflammation in the kidneys, and they decrease tissue hypoxia in the kidneys and improve oxygenation, and eventually fibrosis, which is the final pathway for any type of kidney disease, is less on patients who are taking those medications. There are other proposed mechanisms like they improve endothelial dysfunction, but we don't really have strong evidence yet. How do SGLT2 inhibitors improve tissue hypoxia? When we discussed earlier, right, the SGLT2 inhibitors reabsorb glucose and sodium to the cells, right? So, and that sodium is pumped to the basolateral side, and this is an energy-consuming mechanism. So when you have more glucose in a patient with diabetes, that will be reabsorbed together with the sodium. So you will have more sodium in your luminals, in your cells, and that has to be pushed out. That is an ATP consuming process and causes hypoxia and energy consumption. And instead of that, when you have SGLT2 inhibitors on board and block those receptors, and instead of making your nephrons busy, you're losing the sodium and the glucose in the urine, and you decrease the energy demand, and hence you decrease tissue hypoxia. Another mechanism is, especially most of the patients we have, type 2 diabetes patients, most of the time they're obese, overweight, and they have increased accumulation of free fatty acids in the podocytes, in the mesangial cells. And free fatty acids are toxic and cause inflammation. And because SGLT2 inhibitors force your energy mechanism from the normal glucose utilization to alternate pathway, you'll be consuming more of your free fatty acids, and those free fatty acids that are accumulated in the podocytes, mesangial cells, will be reabsorbed, and you will have less toxicity from accumulation of lipid in your nephrons. Again, on the right side, this is additional benefits of SGLT2 inhibitors in the kidney. They cause less podocyte loss, hence less albuminuria. They decrease inflammation, and they decrease endothelial dysfunction and decrease fibrosis. So now we know that SGLT2 inhibitors don't only work in a single pathway by decreasing glucose, and that they have other mechanisms by decreasing energy consumption, decreasing fibrosis, decreasing inflammation. If they have all this benefit, can we use them in patients who have kidney disease but no diabetes, even if they are essentially initially marketed as medication for diabetes? And that's exactly the next study looked into. So DAPA-CKD is the next study that was published probably in 2020 in the middle of the COVID pandemic. So they compared the use of dapagliflozin in patients with chronic kidney disease, either with diabetes or without diabetes. So the study population included those about 18 years of age, and compared to Credence, which had a cutoff GFR of 30, the GFR even dropped further to 25. So the study population included from 25 to 75. And again, they included patients with significant albuminuria. And again, this dapagliflozin was used in the background use of maximally tolerated ACE inhibitors, or ARBs. most important thing for our purposes is patients without diabetes were also included. We'll come back to the study here. So patients who are excluded in this study, type 1 diabetes patients are not included because of the risk of DKA, and we know we'll look into that later, but SGLT2 inhibitors cause more euglycemic DKA, so we cannot include type 1 diabetes patients. Patients with polycystic kidney disease were not included because some animal studies have shown SGLT2 inhibitors cause more cyst growth. Those patients taking any immunosuppressive therapy, like patients with kidney transplant taking immunosuppressive therapy, were not included in the study because there is a theoretical increased risk of urinary tract infection with SGLT2 inhibitors, and they don't want to expose these patients to any sort of infection. You can look into the other exclusion criteria, but just remember patients with type 1 diabetes are not included. And this one is being revised right now. Patients with organ transplantation, I'm even giving to my patients, so we'll look into that later. But in the study, type 1 diabetes patients and those with organ transplant were not included. So again, coming back to table 1, the study population was around 60 years of age, and their mean GFR was even lower than the one in the Credence trial, which was around 57. The one on dapagliflozin even lower to 43. And those with GFR very significantly low, stage 3B and low, was higher, like almost 45% of the study population have a GFR less than 45 and below. And the average albuminuria was also significantly higher. Those with type 2 diabetes, where 67% of the study population have diabetes. But for our purposes, what I'm interested in, 32% or 33% of the study population didn't have diabetes. And again, this was done on the background use of S inhibitors and ARB. So if you add the use of S and ARBs, almost 100% of the study population was either or S inhibitors or ARBs. This is the distribution of the study population by disease cause. The blue one is diabetes. This one is non-diabetes related kidney disease. And if you further classify it, you can see hypertension related, even IgA was listed here. The blue one here is 6% of the study population was having chronic kidney disease because of IgA nephropathy, which is the most common cause of glomerular kidney disease in the world. So what did we learn? Again, from DAPA-CKD, you can see the primary composite outcome is much lower in patients who've taken dapagliflozin. The same story we saw in Credence, and again here, the risk of progression to end-stage kidney disease or doubling of the serum creatinine or progression of kidney disease is much lower in patients taking dapagliflozin versus those taking the standard of care. So as you can see here, the benefit again starts early. The p-value is very, very low, and risk reduction is almost 40%. This is just the renal specific composite outcomes. Again, when you look into just renal specific outcomes, the benefit even is higher. There's almost 50% risk reduction when patients taking dapagliflozin versus standard of care. This is looking into the cardiovascular and hospitalization risk. Deaths from any cause, again, same story. So you'll be seeing it again and again. Benefits is across the board. This is, I think, the GFR decline. As you can see here, GFR always declines in the beginning with SGLT2 inhibitors. I discussed earlier in the mechanism of action, SGLT2 inhibitors decrease glomerular capillary pressure. Less capillary pressure means less GFR, but when you decrease the pressure in the glomeruli, you decrease burnout over time. That's why those taking SGLT2 inhibitors maintain their GFR over a long period of time compared to those just taking the standard of care. So what is the next thing? We found out SGLT2 inhibitors have significant benefits for kidney disease. We found out that their benefit is not actually limited to those with diabetes. Those who don't have diabetes also have significant risk reduction. The next thing is, what is the lowest GFR we can use for patients taking SGLT2 inhibitors? So on Credence, the cutoff was 30, DAPA-CKD was 25, and then here comes the empagliflozin and CKD. So enrollment takes as low as 20. So anyone with GFR of 20, which is very close to defining as kidney failure, can be enrolled in the study. So inclusion criteria was for either a GFR between 20 to 45, or those who have GFR 45 and higher, but who have albuminuria. So empagliflozin study, the CKD study actually pushed the study even further in the risk stratification group. So they are in the most red part of that heat map we saw earlier. So this is a distribution of patients with chronic kidney disease. Those with GFR less than 45 were almost 36%. Those between 45 and higher albuminuria. So if you add these two, this is the high risk groups in terms of CKD progression. So the CKD have the very highest risk of patients in terms of chronic kidney disease study. Again, if you look at the study, the average age of the study participants was 63. The mean GFR was even lower. It's lower than we had in Credence, which is 57. In DAPA, it was around 40 something. And in the CKD, it's even lower. This is the mean average of the whole study population is 37. And again, most of the study population has been using ACE inhibitors or ARB. So 85% of the study population was taking ACE or ARB. And another thing I want to highlight, probably for my nephrology colleagues, almost 1/3 of the study population, they have glomerular disease listed as the cause of their CKD. So it may give us a chance to look into maybe if SGLT2 inhibitors may work in this group of patients. Again, I'll look into their primary outcome, progression of kidney disease or deaths from cardiovascular study. The CKD showed again significant risk reduction, almost 30% risk reduction. This is subgroup analysis for CKD. So you can see here, is the benefit consistent in those who have diabetes or not? You can see here, if you have diabetes, the risk reduction. So this is a line here, right? So if the study touched this line, you know that the difference is not significant, but it's way over here. And those with diabetes have significant risk reduction, almost 36%. But that benefit is also, again, present in those who don't have diabetes. So there's almost 20% risk reduction, even if you don't have diabetes. The urine albumin creatinine ratio, is it different when you have lower albuminuria or higher albuminuria? Those who have significant albuminuria had higher benefit from those when they take empagliflozin. Again, you can see even if you have very minimal level of albuminuria, you still have some benefit, but it's not as significant. But if you take the whole composite outcome, the benefit is here, the 0.72, which is almost 30% risk reduction. Looking into some adverse events, except the early studies with canagliflozin, the incidence of urinary tract infection, hyperkalemia, acute kidney injury, dehydration, lower limb amputation, if you can see, there is no significant difference between those taking SGLT2 inhibitors and those taking the placebo. So we can fairly say those medications are safe to give to those group of patients. UTI is mentioned many times as a possible risk, and the reason why we don't give it to patients with organ transplant or immunosuppression. But from the data from you see here, there was 52 incidents of urinary tract infection in the empagliflozin group, and there's 54, and there's no significant difference between those two groups. Of course, I see a lot more of like genital mycotic infection, like candidiasis and the likes, but in the study population, it hasn't shown a big difference. But just from abundance of caution, I would advise patients who, especially women, elderly women, that I prescribe this medication, there will be a yeast infection. You may see, candidal infection, vulvovaginal candidiasis can happen because there is glycosuria. And I tell them if that happens, take some medications, but something easily can be treated. It's not a reason for you not to give the medication though. But ketoacidosis is, of course, higher. Compared, there's 6 incidents of ketoacidosis in the empagliflozin group versus just 1 in the standard of care group. We have seen this across the different studies. Euglycemic DKA happens more in patients taking SGLT2 inhibitors, but they cannot do comparison study because the number of events that happened was very minimal. So again, this is a recent publication in the Lancet. This is meta-analysis of all the major trials, including Credence, DAPA, and IMPA CKD trials. And they plugged the numbers and looked into if this is consistent across the board. So you see the Credence trial, the DAPA CKD, and the IMPA CKD trial, and all of them show significant risk reduction, almost somewhere between around 60% here, which is a hazard ratio of 60%, which means risk reduction of 40% across the board. So very interesting thing about the SGLT2 inhibitors is their benefit that transcends beyond diabetes and other commonly seen kidney disease. In the DAPA CKD study, we had almost 260, 270 patients who have IgA nephropathy. In the IMPA CKD, we had almost 800 patients who have IgA nephropathy. This is a higher number than any type of study we have done for patients with IgA nephropathy. And it's unbelievable that the risk reduction in patients with IgA is almost 50%. In the IMPA CKD group, there is a 50% risk reduction in the primary outcome of slowing the progression of kidney disease. This is better than any immunosuppression therapy that I'm giving to patients with IgA. So I prescribe it to those patients who are, not actively taking other medications. So it's something probably that will have further study. But again, this is a secondary analysis. We didn't look into benefit of IgA and SGLT2. This is from a subgroup analysis from what data we have. But again, it showed good benefit in patients with IgA. We didn't have enough number of patients with FSGS and other glomerular disease. But overall, if you look into total glomerular disease, there's, again, a good risk reduction. And I would definitely consider for any patients with proteinuria or albuminuria with any type of glomerular disease, I'll be adding SGLT2 inhibitors. Another safety concern that has been raised because of the early CANVAS study, there was a mention of increased risk of amputation or lower limb amputation because of the CANVAS study, but that has been replicated on the other studies. There's no study that has that doesn't cross the line. So overall, I think it's better to be safe and look into peripheral vascular disease, look for any active wound or ulcers when you prescribe SGLT2 inhibitors. But this is only a signal seen on the CANVAS trial, on the canagliflozin trial. This has not been shown on the DAPA CKD and IMPA CKD, so I cannot say for sure there is increased risk of amputation. It's just one signal that we saw. So from this meta-analysis study of all the population, all the studies that have been done so far, if you look into it, without including the CANVAS study, is 1.06, and it crosses the 1 mark, which means there's no significant difference. But when you include the CANVAS study, there is slight increased risk. There's 15% increased risk of lower extremity amputations, but it's very hard to say whether this truly exists or not. Again, looking into ketoacidosis, all trials have shown there is increased incidence of euglycemic DKA or diabetic ketoacidosis in patients taking SGLT2 inhibitors. But again, remember the number of incidents is very, very minimal. You have study participants in the 10,000s and even above. The number of events that happen, look at here. In the IMPA CKD, you have 15,000 study participants. Actually, no, 3,000 and 3,000 here. The number of incidents that happened was 5 and 1 here. Let's look into Credence. You have 2,200 in the study population. The number of events that happened was only 11. So the risk is higher, but overall, the number of events that happen is low. This is who are the type of patients who have DKA? Which type of patients have an increased risk for DKA? They looked into those in the Credence study. Those who have been on background insulin therapy for many years, those who have diabetes for many years, or who have A1C when you start, when their A1C above 10% when you start, they have a higher risk of euglycemic DKA when you start with SGLT2 inhibitors. So probably what I would do is, if a patient comes first time, I would first do a good control of their diabetes, bring down their A1C to 7 and 8, and then you can start their SGLT2 inhibitors. And again, DKA is more common when they're fasting, when they're not eating. So if a patient is sick in a hospital, having nausea or vomiting, they are at higher risk of developing the euglycemic decay. So you can tell them about the sick day rule. Whenever you feel sick, not feeling well, hold the SGLT2 inhibitor for a couple of days. You can start taking it, after those days. The risk of decay is higher than stopping the medication for a couple of days. So these are the adverse events that I want you to look into carefully. The euglycemic decay. Amputation, the signal is very, very weak. It's only seen in one study. And we didn't see any increased risk of UTI, but definitely there is more incidence of genital mycotic infection, like yeast infection, that can be treated easily. And of course, there is volume depletion. They act like as a diuretic. So if a patient is having volume loss, nausea, vomiting, diarrhea, maybe you can hold for a few days before starting. There is no increased risk of acute kidney injury with SGLT2 inhibitors. So in conclusion, SGLT2 inhibitors reduce the risk of kidney failure. They reduce the risk of deaths from cardiovascular causes. They decrease hospitalization, especially in a country like ours, where resources are very limited. Spending a lot of money on, expanding dialysis care, of course, we need to do that, but making those medications available and stopping the progression of kidney disease to dialysis would be more important. We have to make sure that those medications are available. And with decreased hospitalization, that reduces burden in our healthcare system. It prolongs survival. So I think it should be a standard of care. It's a medication that you all need to be familiar with all this benefit that we've seen so far. And again, this benefit is seen not only in patients with diabetes, but it also has a benefit in patients who have no diabetes or who have just IgA disease or other glomerular disease. So, and the kidney protective effects goes not only in the early stage of kidney disease, but you have the benefit that goes to even advanced kidney disease. CKD enrolled patients with GFR as low as 20. So the benefit extends. There's no point where you say, this patient has very advanced kidney disease. What can I do now? Like, there's no benefit. The benefit still goes to patients who have advanced kidney disease. So what is next? This for SGLT2 inhibitors, can we use them in patients with kidney transplant? There are some papers that looked into SGLT2 inhibitors and kidney disease or patients with kidney transplant. I don't know your exposure with patients who have kidney transplant, but you may come across one. So it's good to know. I'll be very careful to start those medications, especially in the first year of kidney transplant, because the first year is when you have a higher level of immunosuppression. They just have their kidney transplant, they have induction immunosuppression. You're putting them on a strong immunosuppression. They are at increased risk of infection. If there is still that, there's glycosuria, glucose in the urine, would that cause more UTI? The data doesn't say there is increased risk of UTI. Maybe mycotic infections are there, like the candidiasis and so. So a lot of prescribers are very, anxious about prescribing those medications, but of course there are studies done. There's only one retrospective or trial, but the others were case series, and the incidence of those studies did not find significantly higher rates of infection with SGLT2 inhibitors. So all these studies didn't find increased risk of UTI or genital mycotic infections. So general guideline, if in case you came across with a patient with albuminuria, kidney disease, and kidney transplant, just rule of thumb, maybe wait at least 1 year they are out of their kidney transplant. If they have history of recurrent UTI or history of recurrent mycotic infection, maybe you want to consider a different medication. If they are hypotensive, if they are having from medication, they're prone to volume loss for many reasons. So you may don't want to prescribe this medication in the first year or in a patient who has recurrent UTI. This is a study I was a part myself. We did it in our hospital at Jefferson. We looked into increased risk of urinary tract infection, increased risk of UTI in patients who have solid organ transplant, whether kidney transplant or liver transplant or pancreas transplant. And then we had 20 patients we looked into. There was no increased risk of UTI. There was no increased risk of acute kidney injury in those patients. They were safe to use, and I still prescribe it on selected patients with kidney transplant. The first large data we have on efficacy of SGLT2 inhibitors in patients with kidney transplant came from a Korean study that looked into 2,083 patients with kidney transplant. But again, this is a retrospective study. But like the other trials, again, the benefit of slowing the progression of kidney disease, days, and other benefit was translatable to patients with kidney transplant as well. So we know they are safe, not from a larger study, but from smaller studies. From a larger retrospective study, we have this data that showed benefit again that translate into patients with kidney transplant. So we know that they have benefit in patients with kidney disease and heart failure. Do they have any other benefits? We have some but evidence that the SGLT2 inhibitors improve magnesium reabsorption. Some patients are prone for hypomagnesemia. So patients taking SGLT2 inhibitors have less incidence of hypomagnesemia. They stimulate erythropoiesis synthesis, so they can help treat anemia to a certain extent. Nephrolithiasis or kidney stones, because when you have glycosuria, the glucose drags volume or water with it. So your urine volume will be higher when you're taking SGLT2 inhibitors. The first thing you do for a patient with kidney stone is tell them to drink more water. You need to make more urine, because that's how you're going to stop from the kidney stone from building up. So somehow SGLT2 inhibitors, because the way they work, they can help in management of nephrolithiasis as well. Hyponatremia, again, because there's glycosuria, it means there's increased urinary free water clearance. They can help manage hyponatremia, or at least decrease the incidence of hyponatremia in the patient that you're treating. This is a mechanism by which SGLT2 inhibitors increase reabsorption of magnesium. Because there is distal delivery of sodium, the luminal charge will be more positive. That helps transcellular reabsorption of magnesium in the distal tubules, but the mechanism is not really necessary. So coming back, so KDIGO, which is the international body that gives us a clinical practice guideline into the management of kidney disease. Now it lists, this is a 2022 guideline. It lists for diabetes kidney disease, it puts metformin and SGLT2 inhibitors as a first-line therapy. You can use metformin. So when you start, the first thing is, of course, lifestyle therapy, telling them to weight loss and other things. And then next thing, if you have to start medication, you have to start them on metformin and SGLT2 inhibitors. You don't have to wait until things do not work out. So you can start from here. You can use GFR until GFR is less than 30 or less. When GFR is low, you have increased risk of lactic acidosis with metformin. You don't want to use that. When GFR is less than 45, you have to decrease the dose. But SGLT2 inhibitors, we know you can use them safely until GFR of 20. You may even use them further. In the study, for example, in empagliflozin CKD study, those who were started with lower GFR, their empagliflozin was not stopped until they started dialysis. They used it continuously until they didn't start them less than 20. But if you are already started on SGLT2 inhibitors, they didn't stop it on the study, and they didn't see any increased risk. Maybe there will be another study that would look into use of SGLT2 inhibitors in patients on dialysis. Maybe we'll come to that, because the mechanism is much wider than their proposed mechanism. After these two medication, you can use GLP-1s. They also have some weak signal in terms of cardiovascular protection and kidney protection as well, and the list goes on like that. But the point I wanted to highlight is metformin and SGLT2 inhibitors are first-line treatment for diabetic kidney disease. This is a practice guideline. So first line, you have diet, exercise, smoking cessation, weight loss. And when you go to the second level of the pyramid, you have metformin, SGLT2 inhibitors, RAS blockade, and statin. You should make sure that all of your patients with diabetes kidney disease are on those medications. No excuse not to have them on RAS blockade, no excuse not to put them on a statin, and SGLT2 inhibitors. Of course, I know the cost is very prohibitive for SGLT2 inhibitors, but I saw in the chart earlier that the Ethiopian Diabetic Association is providing this medication for free. I don't know how long it will continue, but use the chance while you can. and make sure that your patients are on board. I'm just going to conclude by giving you some additional tips on what to know when you prescribe SGLT2 inhibitors. So you can use them up to GFR of 20, and make sure patients who have albuminuria or heart failure on top of the kidney disease are priority patients, because they will get the maximum benefit. You reduce complications from heart failure, you reduce albuminuria, and also slow down the progression of kidney disease. Potential contraindications, genital infection risk, patients who are incontinent, bedridden, who have, for example, bed sore ulcers in the sacral area. There is increased risk of, you making them urinate more. There's glucose, risk of infection could be higher. So be selective on the patients. Those who have history of diabetic ketoacidosis, I would avoid. Foot ulcers, again, is questionable, but maybe for canagliflozin, because this is the one study that showed increased risk of amputation. So for patients on canagliflozin, I would be very careful if the patient have diabetic foot ulcers and other things. And those on immunosuppression, to me, like patients on organ transplant, I think the guideline will change soon. I'm actively using SGLT2 inhibitors even on organ transplant patients. So what do you need to do? If your patient already taking medication for diabetes, like insulin, sulfonylureas already, and you're giving them a new medication that could further decrease the glucose in the blood, to avoid the risk of hypoglycemia, what I would do is I would decrease the insulin dose by at least 10%, maybe decrease the dose of the sulfonylurea by half, so that your risk of hypoglycemia would be less. And then, the other thing is volume assessment. If your patient comes with volume depletion, hypotension, and they're using a diuretic, maybe I'll stop the other diuretic and add SGLT2 inhibitors, so that you don't further worsen their hypotension or volume depletion. So these are the medications we have. They come in different groups. So always start at a lower dose. Canagliflozin comes in 100 and 300 milligrams. Start from the 100. Farxiga or dapagliflozin comes in 5 and 10 milligrams. So start from the 5 milligram. Empagliflozin comes in 10 and 25. You can start from 10, and then if they're doing well, you can increase the dose. Education here is what I say, the sick day protocol is if the patient's feeling sick, not feeling well, not eating right, having some disease, for many reasons, but volume depletion is the key. If they have that, tell them to hold the medication for 4 or 5 days or a week. It's not the end of the world if they stop it for a week. They can restart it at a later time. So make sure that you educate your patients about hypoglycemia risk, and then follow up these patients through time. This is again the point that I discussed in detail. You can look into the details of the text later on by yourself. And this is if you want to print out or give a handout to your patients after you prescribe SGLT2 inhibitors, you can give them this. So, you can tell them, you may notice that there will be increased urine output, your blood pressure may be a little bit lower, and then ask them to monitor their blood glucose so that they don't have hypoglycemia, and ask them to follow the sick day rule that I discussed earlier. And if they're going to have a surgery or any procedure that requires them to be MPO, you can tell them to hold the medication for 3 to 4 days before the surgery, and they can restart it after a couple of days. And advise them to avoid keto diets, because that can increase diabetic ketoacidosis. And if they have wound or any ulcers in the foot, to tell their providers. And then look into the genital area to look for any signs of itching or signs of UTI. So this is a good summary of a patient handout. You can print it in Amharic or in any other local language and give the patients this instruction so that you can safely prescribe this medication. So make sure that you learn about those medications, teach your medical students or fellows and other things that you have, so that they understand SGLT2 inhibitors. More than any policy, more than anything that we can do, those are the medication that can decrease the burden of end-stage kidney disease in patients on dialysis. Make sure your patients are on a standard therapy. At least ACE and ARB should be a standard, and you should know how those medications work. Thank you. I am done.
Thank you very much, Dr. Fitsum. I can see our attendees are really happy about the presentation. Before I proceed with the questions, you can take a sip of water, and I'll be sharing the link here to answer the questions Dr. Fitsum has prepared, and we'll be doing the questions after like 10 minutes. We'll give you 10 minutes for doing the questions. And I can see there are a few questions on the chat box. Shall we entertain them now, or?
We can do the questions, yes.
All right. We can start with the first one. What are the specific indications? I think you have told us about the indications and the contraindications, like hypotensive patients, GFR less than 20, and the like, but the specific one, what is the dose, frequency, and duration of this SGLT2 inhibitors?
It depends on the type of SGLT2 inhibitor that you're using. So I saw another question also, like which one is the best to use? The best one is the one that is available. So if you have canagliflozin, that is good. Their safety has been studied. You can use that. So whatever you have and the patient can afford is the best SGLT2 inhibitor you can use. The dose is different because canagliflozin comes in 100 milligram and 300 milligrams. So you can, it's all of them are once a day medications. Canagliflozin, you can give it once a day. The empagliflozin or the Jardiance, it's once a day. And all of them are once a day, but I would recommend starting at a lower dose. If you're using canagliflozin, start from 100 milligram, and then you can increase the dose to 300 milligram. If you're using the dapagliflozin, which is Farxiga, you can start from 5 and increase to 10 milligram. If you're using empagliflozin, you can start from 10 and you can increase to 25 milligram.
Thank you very much. The next question was, how about for pregnant and breastfeeding? Is there any study done on that, or yeah?
No, we have excluded patients who are pregnant, which is unfortunate, but probably, the benefit of SGLT2 inhibitors is, seen over time. Maybe during pregnancy, I may avoid because we don't have strong data. And we talked about increased risk of UTI and mycotic infection. That's something I want to avoid during pregnancy. Increased risk of preterm labor and other infections would be higher on those patients. So the studies did not include pregnant patients, and I think it would be safe to wait the 9 months and restart later on.
The question was, when do we discontinue the SGLT2 inhibitors in patients with AKI?
AKI, because it's an acute kidney injury, it could be volume loss. SGLT2 inhibitors, they work like a diuretic, right? They are osmotic diuretic. They stop the reabsorption of glucose in the proximal tubules, and that causes more urinary free water loss. And that can cause, we saw that they can decrease blood pressure, they cause increased urinary output. So in a patient with acute kidney injury, it's not something you want to do at a diuretic, right? So you want to wait until you have volume resuscitated the patient, find out what's causing it. And then the next thing you want to know is, if the patient's creatinine is going up, is it because of the progression of his AKI, or is it because he added SGLT2 inhibitors? So whenever a patient's having AKI, I want to wait adding, I don't want to add ACE inhibitors or other medication because they can, cloud the picture. But it's also not safe to use because of the volume depletion.
Okay, yes, I can see a lot of our participants are really happy about the presentation. There's another question that says, can we give SGLT2 inhibitors in post-obstructive CKD?
I think, of course, you can use it once they are in a steady state. Like if the obstruction is from BPH, or if it's from kidney stone, or any other thing that causes obstruction, wait probably maybe a couple of weeks until the acute kidney injury has resolved. Make sure that the patient is still not having for example, if it's a prostate issue and the patient is having recurrent obstruction, you want to make sure they're treated, their prostate is taken care of, either surgery or medical therapy, before you start the SGLT2 inhibitors. If that is all taken care of, their creatinine is back to baseline, I would definitely put them on if they have a CKD or proteinuria or an indication.
Yeah. Another question Kibrat asked was, do we prescribe SGLT2 inhibitors in non-proteinuric diabetic CKD? And is there any preference among the inhibitors?
Exactly. That's a point of the study on DAPA CKD, right? Our first answer for Credence was we can use it in diabetes patients, has a lot of benefit. And the DAPA CKD study showed us even patients with non-diabetic kidney disease have significant benefits from SGLT2 inhibitors. And the mechanism we saw have many different ways: decrease hypoxia, decrease fibrosis, so many other ways. So it definitely benefits patients without diabetes, and we have the data for that.
Okay. Thank you, Dr. Fitsum. So I've shared the form, and make sure to do the questions. And once you'll see your results after you do the questions. And we'll be doing the questions together after like 5 minutes. I can see there are other questions in the chat box. Does it have any benefits in cardiovascular accidents?
Overall, they improved the cardiovascular events, but we looked majorly into whether MI or any coronary artery disease, but we didn't look into CVA. So maybe something that we can look into, but I am sure like the risk of CVA is much lower in SGLT2 inhibitors, and we'll probably have to look that down the line.
All right. The last one I think is when to titrate the doses to increase, does the maximum tolerable dose must be achieved?
Yeah. So like I said, I want to start them like at a lower dose initially. Gliflozin, I said, comes in 100 and 300. I start them at 100 just to make sure they are tolerating the dose. But we actually, when they looked into the DAPA CKD, they had, the initial study had patients on 5 and 10 milligram, but both patients had the Canvas study. So they have 100 and 300 milligram on both groups, and then the outcome was not different in the two different groups. But just to be safe for those patients, I would start them at a lower dose and then increase to 300 milligram as see the patient, maybe start 100 milligram, see how they're doing for a few months, up to 6 months, and then you can increase the dose. Maybe in the Ethiopian context, what I would say is if the medication is very expensive, say you have dapagliflozin, Farxiga comes in 5 and 10 milligrams. If you give them 5 milligram versus 10 milligram, they can use the 5 milligram maybe twice longer, right? So I would keep them on 5 milligram and get their benefits instead of like, the cost issue coming up being a problem and they're stopping it. So if a patient can afford it, up titrate it to the maximum dose. If not, I would keep them on the half dose and, so that they can be at least on some medication for a period of time.
Excellent. The last one was, is it better to use in type 1 diabetes?
No, so far we don't have any data on type 1 diabetes patients. They have been excluded from the study because of the increased risk of UTI. I think in the IMPA CKD, there was like 1 or 2% of patients with type 1 diabetes who sneaked into the study. I don't know how they were included, but they were type 1 diabetes patients. The outcome has not been reported, so I would be careful on patients with type 1 diabetes. 1 DKA could be, can be like increased mortality in those patients. So I would definitely avoid SGLT2s in type 1s, at least for now.
All
yes.
right.
There were a few patients in the IMPA CKD.
All right. So I think 10 minutes has been passed. We can do the questions. Can you present it from your end?
What is it? Oh,
the questions, yeah.
Oh, I don't have that. Do you have it?
Let me check. Yeah.
The references are shared on the slides. Make sure that you join the Telegram group and we will share the slides there. Each slide has a reference at the bottom, so any study that I mentioned has a reference there.
Thank you. Let me log in to so we'll be giving you 2 more minutes to do the questions. I can see a lot of people are liking the presentation. Thank you, Doc. So I think we can share it.
Yeah. So what is the primary mechanism of action of SGLT2 inhibitors? You guys can type the answer just to see how much.
Yes, they're saying B.
Yeah, yes, yeah, B. They inhibit glucose reabsorption in the proximal tubules of the kidney, right? Perfect. Second question, which of the following statements about SGLT2 inhibitors in patients with kidney disease is correct? Yeah, C, exactly, right? So A, is it saying it's contraindicated in patients with advanced kidney disease? No. The IMPACT CKD have shown us you can use even as 2 GFRs less than 20. SGLT2 inhibitors are not effective in cardiovascular events. No, that's not true. There is ample evidence that they do prevent cardiovascular events. And SGLT2 inhibitors have a neutral effect. No, they lower blood pressure. Even if it's 3 to 5, they do lower blood pressure. So C is the correct answer. Number 3. Let's go. Which of the following statement is true regarding the use of SGLT2 inhibitors in patients with kidney disease and proteinuria? Can you move it up a little bit? Yeah. Yes, this was a question that I've been asked earlier. SGLT2 inhibitors help decrease the progression of kidney disease in both diabetic and non-diabetic patients with proteinuria, right? So A is not correct. It's not only effective in patients with diabetes. We've seen it can use in other groups too. It doesn't mean it does not have no effect on progression of kidney disease. That's not true. Yeah. All right. So number 4. Let's talk about use of SGLT2 inhibitors. Yeah, correct. We actually have weight loss, not weight gain, but decay is a real risk. Polyuria and polydipsia is true. They can cause because they increase urination. It causes hypotension sometimes, and it can cause definitely genital mycotic infection. So E is the correct answer. Thank you, Saga.
Thank you very much, Doctor, for your excellent presentation. I can see there was a lot of feedbacks. They were saying it was detailed and interesting presentation. We will make sure to have such presentation for the future as well. Thank you for giving us your time, Doc, and have a good day.
Thank you, everyone. Bye.
Bye. So we'll be sharing the PowerPoint on the group as well as the link on our YouTube channel. Thank you for joining us.
I'll send you the updated PowerPoint, Sakana.
All right. Thank you.